Okay, thank you very much. Well, I'll share my screen now.
Yeah.
Is that working? Oh no, hold on.
There we go.
Yes? Okay, that's great. Okay, well, thank you very much for the invitation to do this webinar for Cochrane South Africa. I'm delighted to do this. Just say that I am the Joint Coordinating Editor for Cochrane Public Health. So we have a lot of experience of doing and editing reviews that are in public health. So, there we go. So this is an outline of what I'm going to be presenting. I understand that some of you maybe not have a lot of experience in systematic reviews. So I'm going to talk a little bit just about the whole rationale for doing reviews. And then I've got sort of 3 things that I'd like to look at about how they might be different in public health. So looking at whether or not the questions themselves are different, then how you might incorporate diverse data, and then issues when you're actually synthesizing the data. So first of all, sort of principles of systematic review. Well, this is really a kind of obvious thing that we always are accumulating more and more knowledge through research, and we need to make use of it. And there's been lots of calls that researchers make more use of existing knowledge so that we improve the quality of the future research, as well as using evidence to make decisions that are more evidence-informed in policy making and by decision makers. But of course, this can be a challenge because there's so much evidence and knowledge that it's very difficult to, make sense of it all. And when we are doing these kind of literature reviews generally, you can just feel completely overwhelmed with the volume of information and literature that's available. But there are also issues, once you think you've got a method of dealing with it, you come across studies that say different things, so there are conflicting findings, and it can be very difficult to know how to handle that. Then you've got variations in the quality of the studies that you might look at, issues, differences in study design, the risk of bias, even just differences in the way that they've measured the outcomes or the types of populations. How can these things be managed when you're trying to draw conclusions and synthesize data? But the difficulty is that single studies are rarely definitive, and they rarely give you the last answer. They may be very good to relate to a very specific context or a specific intervention, but they're not so useful always for bigger level, higher level decisions being made by policymakers. So we need to find a way of synthesizing evidence, because the more you see consistency of findings across different studies, the stronger and more precise your conclusions will be. But yes, doing a literature review can be difficult and it can drive you a bit nuts. So hopefully you will not end up feeling that this poor person here. And that's why we've developed, not me, but many much cleverer people than me, the scientific approach to doing literature reviews called a systematic review. And really what that means is it's applying a scientific approach to minimize the bias in how you select studies and then how you interpret the evidence. So, don't be confused by the difference between minimizing and eliminating. Everything has bias in it, but a systematic review just aims to take steps to reduce that bias when you're selecting and interpreting data. And the key principles of systematic review are that you're bringing together things that are similar and make sense to bring together. And we'll talk about what we mean by conceptually similar later. Then you're considering the quality of the data that you're looking at. So if all the studies are really very high risk of bias or very poor quality, it should affect the strength of your conclusions. And then everything should be transparent. So that's really sort of a fundamental scientific principle, that you report everything that you have done in the review to make sure that people can see how you've drawn your conclusions. So what do we mean by a systematic review beyond what I've already said? Well, systematic reviews are often described as hypothesis testing, and they're answering a very clear and specific question. And there are key components to a systematic review. The first is, once you've identified your question, you then have to have a search strategy, and you identify the literature that relates clearly to your review question and your inclusion and exclusion criteria. Then you would assess the quality of the evidence that you have, and then you do the synthesis and you bring the data together. So these are the sort of key steps in the review. And because it is actually a hypothesis testing tool, then the key steps in the systematic review have been compared to just primary research. So sometimes people who don't do reviews think that systematic reviews are very different to primary research and they're not as valuable as primary research. Primary research, because you're defining your question or your hypothesis, then you should write a protocol, so you're planning in advance, then you determine you develop your searches and you screen for eligible studies, and that's like the recruitment stage of a primary study. Then you're assessing the quality to ensure the validity of the data, and extract the findings from the studies, so that's like the data collection phase. Then the synthesis is the analysis, and then dissemination. But of course, it's all very well as scientists to be thinking that we want our reviews to be as rigorous as possible, but we can't forget the importance of spending time doing this work. We still need to be thinking that systematic reviews and the outputs are relevant to the people who might use these important evidence synthesis. And systematic reviews are often criticised for not being very useful or very relevant. So here's a quote from a policy maker who we interviewed a few years ago, saying we have extremely high quality, methodologically perfect reviews, but they're completely useless. Now, this is very frustrating because we're always trying to produce evidence syntheses that are actually useful for decision makers, but it seems that that doesn't always happen. And then the next person we interviewed says, you're very well looking for a Cochrane reviews. They're the sort of go-to place when you're looking for evidence synthesis, but they're not always useful because they're so rigorous. The level of rigor in a Cochrane review does take them down the road of saying, well, we're not sure, and that can make it difficult for us compiling the evidence base on whether something works or not. And that seems to be a bit of a contradiction, saying something's not very useful because it's so rigorous. And that's a big challenge for reviews in public health. So as well as being rigorous, we also need to be thinking about keeping reviews relevant, and that means that they need to ask the right question, they need to be accessible to the users and readers, and also, and this is really important, the reviews need to be produced in a timely way. So it's not very useful if a review takes years and years and is very expensive to conduct. So here's an example of a bridge that was built. And by the time, the bridge was built to allow people to travel over a big river that was a major obstacle in an area. I can't remember where it was. I think it was Honduras. And but by the time it took them so long to build the bridge, by the time they built the bridge and opened it, the river had moved. And this can be a bit like some systematic reviews. They're very difficult to do, and so it takes a long time to produce them. But by the time it's completed, the decision maker has moved on and the question is no longer that relevant. And this is a really important thing to be considering when you're doing reviews and when you're making decisions about how big the review can be or should be. So that's just a bit of an overview about why we're doing reviews and some of the key things to consider. So I'd now like to just focus a bit more on public health reviews. And there are 3 things that I'd like to talk you through. Are there any questions at this stage? No? Okay, that's good. So when you're doing a systematic review, and some of you will be aware that you have to develop this review question, and it's usually structured around a PICO, and that stands for population, intervention, comparison, and outcome. So, and that means that you need to be clear in the protocol and in the review question about these key elements of the review and the review question. But when you're doing public health reviews, there might be an extra element that you might want to consider. And sometimes this is changing from PICO to peacock. So put the picture there to try and help you remember this one. And the extra C is for context. So for a lot of public and health interventions, the context may be a very important component of why you're seeing effects in one context and not in another. So you may want to include aspects of context in how you define your question and the inclusion and exclusion criteria for your review. And another issue is study design. So in many public health reviews, there are no randomized controlled trials available, and you have to include non-randomized studies, or you may also want to include qualitative data. And you should include a very clear description and rationale of the included study designs in your protocol. Many people think that systematic reviews are restricted to randomized controlled trials or RCTs, but that's definitely not the case. In fact, only around about half of systematic reviews are based on RCT data. So then we get on to how you might develop a review question, and always keeping in mind the principles of rigor, relevance, and resources. And the issue of relevance is critical here, because you need to be addressing a question that's useful, and that means it has to be relevant to decision makers. It's a question that is answerable by a systematic review, and also it's not going to take so long that by the time you've completed the review, the question is no longer relevant. So the sorts of questions that may be suitable are often quite difficult to determine. But I've got a list of some questions here about the kinds of public health questions that you may have come across. And these are the kinds of things that decision makers may, questions that they may raise and they may want you to answer. So the first one is, does international aid empower women? Another one, what are the effects of mobile money? Another one, what's the effect of marketing discretionary foods? So that means foods that are high fat and salt or sugar on consumer behaviour. But I don't know if you have any sort of thoughts of these questions at the moment. They're all really interesting questions. They're all very important questions, and really critical to sort of questions around the determinants of health, and the answers to these questions could show huge changes in people's lives and their income and their ability to take control of their own health. But the problem with these questions is, although they're interesting and important, they're very, very broad. And if you're going to do a systematic review, it's very difficult to deal with a question that's very broad and not very well defined. As you can imagine, these questions include, they don't really say the sorts of outcomes they're interested in. So, for example, does international aid empower women? International aid covers so many things. What would that include? Would it just be a measure of the actual money that's spent, or would it be focusing on specific programs? And then how do you assess women's empowerment? Very difficult to define that. And this is the kind of thing that in a protocol you would have to define. But I think you would probably have to also limit the question down to be a bit narrower. Otherwise, you will end up doing a review that will take many, many years, and it's very likely that you will give up before you've completed it. And that's a big waste of resources. So just as an example, Well, I'll give you an example in a minute. So when you're refining your review question, you want to make sure that it's relevant and manageable within the time scale, because even questions that seem simple, like what's the effect of the recession on health, or how can we empower women, they seem very simple, they seem interesting, seem important, but they can be beyond manageable in a systematic review situation. And equally, you can have questions that are too specific. So I just made up a couple of questions here to try and illustrate what questions might be too specific. So the effect of eating chocolate chip ice cream on a particular health measure, or the effect of a national election on unemployment on a very specific population. So you can see that some of these, well, the chocolate chip ice cream question may not be very useful, but say the question about the effect of elections on unemployment in a particular population may be useful, but it's not going to be answerable by a systematic review. Some of these specific questions are more relevant for primary studies rather than a systematic review. So there's a difficult balance to be struck when you're developing a systematic review in public health between doing something that is relevant and that is manageable and that is not too specific. So just to give you an example, this was a work that we did a long time ago, and we were interested in conducting a review of the health impacts of employment interventions. But we spent 6 months trying to work out really what the question was and looking at the literature to see what a sensible question would be. And we employed a researcher to do that. And the original question, really, it was clear, it was far too big and far more than we could ever manage in a review. And what we ended up with, I've put the question down here, how it became a review that we could actually do. So it was much more specific. It was looking at the health impacts of work-based interventions, the impact on the psychosocial work environment. So you can see we narrowed the question a lot further down and made clear the outcome that we were interested in, as well as the type of interventions. Okay, so is it true that public health questions are more complex than other systematic review questions? Well, I'm not sure that's totally true. I think it's often the case that they are very broad, and the PICO or the peacocks are often broader. But here's an example of a public health question up here that was used in a review. What are the impacts of housing improvement on health and social determinants of health? That's quite a broad question. And then you've got a question from a clinical review, aspirin for acute treatment of episodic tension type headache. So that's a very specific question, or a very specific review title. The intervention is very specific. The use even specifies the use of the intervention, and it's very specific about the particular outcome. Oh, hold on. To turn over, as well as the population. But it's not the case that public health questions are always broad. So this question here is a public health question: fortification of maize flour with iron for controlling anemia and iron deficiency in populations. So public health questions can be, review questions can be very specific. But it's very often the case that they are broad. And why are public health questions often quite complex and broad? So this relates again to sort of elements of the PICO. Often we want to include a very broad range of outcomes. So it might not be as specific of health. Also, the interventions are often quite complex, and they might involve lots of different components, and they might vary from one context to another. They might be tailored to a population or to individuals, and also they may interact with other influences in health. So for example, when we did the review of housing improvements, we were aware that changes in housing can affect lots of other aspects of somebody's life, including issues like income, and these might then also affect health. Then there's also an issue of why public health questions can be more tricky, is because the stage of knowledge is often different to clinical questions. So it may be the case that we're not at a stage for lots of interventions to really ask about the effect size and the effectiveness of an intervention. The review might be more useful to say, what do we know about the type of effects that are reported and whether or not there are health effects? And we may not be able to address questions of actual effect size and getting a precise effect estimate. And related to that, the stage of knowledge is the type of evidence that we might want to include. Very often, public health reviews include non-randomized studies, and that makes the review a lot more complicated to do and to apply sort of the principles of sort of scientific rigor to the systematic review. So when you're developing a review question, you need to allow quite a lot of time. And although you might think you're spending too much time on it, it is really worth spending time on making sure the question is right and feasible and relevant and makes sense, because otherwise you will end up in a terrible mess later on. And when you're developing the review question, to make sure the question is useful and relevant, it's very valuable to discuss with key stakeholders and the funder how you negotiate the final question. If you don't do this, your funder and stakeholders could end up being very disappointed that they thought you were going to answer a big question, give them, the answer, and then you end up doing a review that's much narrower. And when you're negotiating the sort of narrowing down of a question, it's really valuable to have their input so that you make the right decisions when you're making decisions about how you define aspects of the PICO. So how do you do that? Well, very often you might want to do this using a logic model. And what we mean by that is that interventions can be like black boxes. So you have an intervention and you look at an outcome, but you don't really know what's going on in between. And a logic model can help you kind of disentangle a lot of that and can help you realize how complicated the original question is, and sort of help you to define some of that. So at a very basic level, it might ask you, by using a logic model, to define the intervention more clearly, then think about the influences of context and whether or not they're important, and then the outcomes, and then influences of sort of mechanisms of how you might get the intervention to lead to an outcome. This might seem a little vague, but I've got an example to illustrate this in a minute. But the use of it is that it can really help to map out hypothesis and sort of highlight assumptions in your hypothesis. It can highlight the complexity in the review question. So when you are hopefully discussing this with stakeholders, it can draw attention to all the range of possible outcomes that you could be interested in, and that might help explain to stakeholders why it's not feasible for you to look at all the different range of outcomes or even all the different range of interventions that might come under the question. And it can also help you really prioritize for the review what is important and what's going to be useful. So here's an example of a logic model that we used, and I'm just using pictures here to illustrate it. So we were interested in doing a review of sort of neighbourhood regeneration projects and how they impacted on health. And it seems an obvious question. But then we thought about it, and the pictures on the right-hand side of the screen are just to kind of illustrate the outcomes that we were interested in. So sort of healthy children, maybe improved lifestyles like reduced obesity and smoking, and then living to a sort of healthy and happy old age. But why do we really think that investing in improved housing and regeneration might impact on obesity or smoking? And when we thought about it, we realized this was not that clear. So what we came up with was a sort of theory of change in a logic model that said, well, we think if you invest in improving neighbourhoods and providing improved housing and improved economic opportunities, you might see improved employment, higher levels of employment, increased income, improved living conditions, and this picture at the bottom is supposed to represent their education. So it was affecting determinants of health. And so we thought we would be interested to look at these intermediate outcomes as well as looking at health outcomes. So that can be a useful tool when you're negotiating the PICO or trying to work out in your review team how you might, the sorts of outcomes that you might be interested in your review. Okay, so any questions at this stage? Okay, I will keep going then. So I think I already mentioned that very often in public health, systematic reviews include heterogeneous or very diverse data. And although it's not unique to public health, I think this is one of the things that poses a lot of issues for people doing systematic reviews in public health. So it may be that you want to include a very wide range of literature sources, and that might include grey literature, so you might not want only to rely on publications in peer-reviewed journals. You may also want to look at unpublished literature, and that presents an issue. And there's also a lot of diversity in the data itself. And there's different types of heterogeneity in the data, some of which you may have come across. I want to focus on the issue of conceptual heterogeneity, because I think that's an issue that is not handled very well in currently in systematic reviews. But I'll just briefly talk about what I mean by statistical and methodological heterogeneity. So first of all, some of you will have come across statistical heterogeneity in a meta-analysis, and that really relates to whether or not your effect sizes, this is on a forest plot, fall on one side or the other. So on this example here, you've got data that is not that heterogeneous because the point estimates are all on the same side of the line of no effect, and the confidence intervals are really all overlapping. So that's good. That makes you would think that looks fine to do a meta-analysis. But in this forest plot here, the point estimates are on both sides of the line of no effect in the middle here, and the confidence intervals are not overlapping. So you would say that there's high statistical heterogeneity here, and it would be difficult to justify doing a meta-analysis here because you would end up really with an average effect that didn't give you an indication that actually, that the effects are lying on both sides. So you would probably wouldn't, you would try to look at why you're seeing heterogeneity, statistical heterogeneity, and then make a decision about how to do the meta-analysis. What do we mean by methodological heterogeneity? Well, as I said, very often in public health there are not randomized controlled studies, so you might include a mix of randomized and non-randomized studies. You might include qualitative data. And as I said, there's a lot of debate about how you manage non-randomized studies in systematic reviews. And so that's what we would refer to as methodological heterogeneity. But another type of heterogeneity is sometimes referred in Cochrane as clinical heterogeneity, but I prefer to call it conceptual heterogeneity because I think that many reviews are not looking at clinical interventions. And one of the common issues that is raised with this type of heterogeneity is people say, well, we can't combine these two things because they're not the same. And they would often refer to saying, well, we can't compare apples and oranges because they are different. And that may be, well, it is true, apples and oranges are different, but at some level they may be the same, and maybe it is possible to combine things that appear to be different, but maybe they have something in common at some level. So maybe if you're interested in fruit salad, that would mean that you could combine apples and oranges and strawberries and kiwi and melon. And decisions about what you can combine in a review, in things that appear to be heterogeneous, really rely on whether or not you think it makes sense, and if there is some level of commonality across something that would make sense to combine, and whether or not there are not enough data to justify splitting and only looking at a comparison of oranges or strawberries or apples. So here's another example of how people think differently about heterogeneity. So maybe in a review of fruit intake, what would count? I think the fruit salad would definitely count, but would you include a study that had looked at an intervention of these fruit chews? Probably not, I'm thinking, but there are lots of things in between that you might think, oh, that might be included. A fruit smoothie, it has fresh fruit in it, would that count? Fresh fruit tart, would that count? Ooh, tart and custard. Cooked fruit, does that count? Banana split, fresh fruit. And people will have different views about how similar these different things are and whether or not they can include them in a review or in their PICO. And these are the sorts of decisions that you will have to come across often in reviews. About at what point do you decide, no, that doesn't fall under our inclusion criteria. So, you will come across heterogeneity all the time. And the appropriate management of the heterogeneity will really depend on what's appropriate, what's going to be useful and relevant to the decision maker, and the quantity of available evidence that addresses the specific issues that you're interested in. Because you can make everything heterogeneous. You know, within an adult population, you'll have variations in hair color, in ethnicity, in gender. Still hear me? Oh, okay, sorry. I just saw a message saying my audio connection had been lost, so hopefully you can hear. So you can make everything heterogeneous, and sometimes that's not very helpful. And this is not just an issue in public health. I think you really can make even the most simple of interventions heterogeneous and complex. For example, if you prescribed a cup of tea, that seems like a very simple intervention. And yet, you could make it very complex and you could identify a lot of heterogeneity in the intervention. How much tea should the person drink? What type of tea should they drink? How long should they brew it for? How hot should it be? When should they drink it? Will they take milk, sugar, biscuit? So you can make even the simplest of interventions really quite complex, and that means you could identify a lot of heterogeneity. So heterogeneity in the PICO is really a matter of perspective, and there is no kind of hard line, but it's the sort of thing that you will work out in your review team about what makes sense. And when you're managing your PICO, you want to develop a clear structure for your synthesis so that you are clear in your own mind, but also into the reader about how the PICO is organized and how the synthesis is structured or organized, and how you've made decisions about grouping interventions or outcomes in the review. And this is often called lumping and splitting. And again, as I've said, when you're making these decisions, you should be thinking about what's going to be useful to decision makers, and you might want to actually make these decisions in discussion with a group of stakeholders or funders. And keep bearing in mind what's going to be feasible in your review. And there's very useful guidance on this recently published in the new Cochrane Handbook Chapter 9 if you want more information about this. So lastly, I'd like to talk about synthesis. And the synthesis is obviously the sort of final stage of the actual review. And the issues of heterogeneity then affect the type of synthesis you can do. Very often, people think that systematic review equals meta-analysis. But in fact, that's not the case. Only about half of systematic reviews rely, in fact, fewer than half in the health field totally rely on meta-analysis, and there are other methods of synthesis that are used. So the two are not synonymous, although, yeah, they are often confused. And I've talked a little bit about heterogeneity, a lot about heterogeneity, and the types of heterogeneity that you come across in a review will affect the sort of synthesis that you can do. So here's a very interesting paper from over 10 years ago. And this is just to highlight that people have different views about when you can do a meta-analysis and when you shouldn't. And this paper is saying that people often avoid doing meta-analysis, but they don't give a good reason for it. And these authors are recommending that people should always, if possible, do a meta-analysis, even if it means they have to interpret it with a lot of caution. So if you're interested in this, I'd recommend going and reading the paper, because it is a very useful paper. But I want to talk about examples of when you can't do a meta-analysis, because very often in public health it's difficult to do a meta-analysis. So the reasons that people avoid doing meta-analysis are for reasons of heterogeneity. So it might be statistical, methodological, conceptual. Or another common reason is that not all the studies provide data that allow you to calculate a standardized effect size. So I'll give you an example of what we did in a review here. So we plotted all the standardized effect sizes here, and on a forest plot. We didn't meta-analyze them, and you can probably see why, because there were lots of similar outcomes from the same study. So here we have in Howden-Chapman A, 1, 2, 3, 4 outcomes, all respiratory outcomes, and then another study by the same author with about half a dozen similar outcomes. And we didn't really know what to do. If you look at the specific outcomes, you will see that although they're all respiratory outcomes, they're all quite different. And I don't think any of the studies reported exactly the same outcome. So we're really in a difficult situation knowing what to do with these data, but we were keen to do something with it. Another difficulty with this forest plot was that this represents 1, 2, 3, 4, 5 studies, but there were another 2 or 3 studies where we couldn't calculate standardized effect sizes for to put into this forest plot. So if we had just chosen one outcome from each of these studies and done a meta-analysis, we would have been underrepresenting the evidence that we had, and potentially that could introduce bias into the findings. So I'm just going to talk, come back to what we ended up doing in that review, but I want to just go through the sorts of alternatives to meta-analysis when you're doing especially particular intervention reviews. So one thing you can do is report the median effect or the range of effects. Another approach is to do a synthesis of p-values. And another approach, perhaps the crudest approach, but actually the most common approach, is to report the effect direction. And what we mean by effect direction is just whether or not there was a positive, a negative, or no effect reported in a study. And if you use one of these methods, I'm sure you're already thinking that that is quite different to a meta-analysis of standardized effect sizes. You're not really getting a precise effect estimate of the effect size in this type of synthesis. And so the question is different. If you end up doing this type of synthesis, the question that you're answering is slightly different. So here I've got the different questions that you will end up answering. So if you do a meta-analysis of standardized effect sizes, your question is about what size is the average effect. If you are summarizing the effect estimates, like the range and the median, you're answering questions about what the range and distribution of effects is. If you're combining p-values, and I've only ever seen this done once, and I'm not sure really what the value of it is, you're answering a question about, is there evidence that there's an effect in at least one study? And if you base it on effect direction, then you're just answering a question about, is there any evidence of an effect? So are there any questions at this stage? I see some things in the chat box, but I haven't been able to read these.
Yes, there are. We have a question from Eleonora. It says, in case of a high statistical heterogeneity, I-squared of 99%, would you recommend synthesis of results in meta-analysis using a random effects model to calculate code point estimate, summarizing results from 5 studies?
Well, I think if you have 99% of an I-square, that's extremely high, and I think you would really want to go and look to see if you can explain that heterogeneity. If that heterogeneity persists, I think you would really, I mean, it's a bit of, people have different views on this. Personally, I wouldn't go ahead even with a random effects model. But I think without seeing the forest plot and sort of knowing the data a bit better and having looked at what might explain the heterogeneity, I think you can't say there's a definite rule of yes or no.
Hi, Hilary. I also have a question. Often it's this is Solange. Often it is easy to assess heterogeneity when you have a forest plot and you have your I-squared and everything. But in the review I'm working on, for example, sometimes we don't have the 95% confidence interval. We don't have all the numbers that we need to have. We can't put things in a forest plot. Is it okay to just look at whether the direction of effect varies? But if we look at that, we're also not counting in if the result is imprecise or whether it's clinically significant or not.
That's a good point, Sanan. So if you were doing something based on direction of effect, you're not getting a precise estimate. That's definitely true. And I think, it's interesting because we've been looking at a lot of reviews over the past couple of years, and very often when people don't do a meta-analysis, they end up doing a vote counting sort of approach based on direction of effect, but they don't say that because nobody's allowed to use that word vote counting, but we're trying to reclaim it because that is what people are doing. And I think there's still quite a lot of thought and work to be done to see how we can use this approach in a way that is still relatively rigorous. I think for me, I think I take a pragmatic approach, and I think that's the view also of the group that I've been working with on the Synthesis Without Meta-Analysis project, that people are making decisions when they can't do a meta-analysis based on direction of effect, but it's not transparent. And if we can at least get that to be reported transparently, then you're making use of best available data. But there are, I think, discussions to be had about when you decide there's no effect, or when you decide what's the threshold, like you were suggesting, sort of clinically important effect. So I think there's still quite a lot of discussion to be had about that. Okay, so will I keep going at the moment? I'm nearly finished. I just want to talk you through an example of what we did with effect direction in a Cochrane review. So we ended up, because we couldn't have standardized effect sizes for all the studies, we just devised a common metric or a standardized metric. So rather than a standardized effect size, we used a standardized effect direction, and we had a kind of algorithm to prepare that. And we used an upward arrows to indicate a beneficial effect, a downward arrow to indicate an adverse effect, and then a sort of sideways arrow for either unclear or no effect or mixed effect. And then we plotted these onto a table. And this is what we ended up with. So this is maybe quite a difficult thing to look at on if you haven't seen it before, but I just want to show that, you know, we presented data on, I think, 10 studies here on quite a small page or less than a page. We were able to provide the sources of the data over here, the study names, the study design, domains indicating whether or not there was an improvement in the outcome or a no clear effect or a deterioration in the outcome. And I think recognizing that this is still crude, but it's a lot more transparent than what people have been doing. And we used the arrow size to indicate the study size here. Oh, where's my arrow? Here we go. So that's not effect size, because this does not look at effect size. And if you want to look at it, if it's a bit easier to look at here, you can see the arrows indicating improvements in this particular domain, or unclear or conflicting findings here. And we've published the methods that we used for this, if anyone's interested to know more about it. We also used colour to indicate statistical significance. So the dark arrows indicate that this was a statistically significant finding, and the grey arrows indicate that it wasn't. But in the recent Cochrane handbook, I think that people, the view is that that's problematic to use statistical significance. But I think there's probably more discussion around this to be had. Are there any questions about the effect direction plot? Okay, so I think, and kind of just finish off, I think regardless of the types of synthesis that you're doing, the principles of good scientific synthesis remain the same. It needs to be transparent. You're synthesizing things that have some commonality, and you make that clear as the author at what level you think the things that your synthesis do have a commonality, because some people may say, oh no, these things are so different you can't combine them. And then you're drawing conclusions in light of the quality of the evidence. And like I say, currently people are doing synthesis based on effect direction, and it's often described as narrative synthesis. But we've done some work looking at this, and very often it's very poorly reported, it's not transparent, and so it really undermines the whole principles of using a systematic and scientific approach. And we're trying to move away from the term narrative synthesis and use synthesis without meta-analysis. And this is based on work that has been funded by Cochrane over the past couple of years, and also the new Cochrane handbook chapters that Joe Mackenzie and Sue Brennan have produced. So if you're looking for more guidance on this, I would recommend going to the Cochrane handbook chapter 12. So what we've done in this work funded by Cochrane is we've developed reporting guidelines for synthesis when you don't use a meta-analysis. The project was originally called ICONS Quant, but because we're moving away from the term narrative synthesis, we're now moving to this name, synthesis without meta-analysis. We haven't published the findings of this yet, but we're hopefully be submitting for publication in the next few weeks. And the sorts of things that are in the reporting guidelines is to improve sort of reporting of the structure of the synthesis and the groupings that are used in the synthesis, then the common metric or standardized metric like effect direction, the method of synthesis, then how you present your data, and then how the conclusions are drawn. So if anybody's interested to know more about this or to join our network, we're hoping to set up a virtual network for further discussion and learning, and I will have 2 webinars when we launch that network that will be hosted by Cochrane. If anybody wants to join that network, please email me or my colleague Barry Campbell after the webinar. So I think that's, yeah, so I had a sort of summary slide saying, are systematic reviews in public health so different? Well, I think it's yes, but no. The principles are the same, and they're not unique. There are many other review topics where you have lots of heterogeneity and broad questions. But I think in public health, these are very common questions. They're very common issues dealing with heterogeneity. So it's a kind of yes, but no. So thank you very much. So I'm happy to stay for questions if people still have questions.
There's a question from Martha. How do you handle methodological heterogeneity in qualitative and quantitative data?
So it's a good question. And I think you have to think, well, I mean, first of all, with quantitative data, if you have randomized studies and non-randomized studies, generally the guidance is that you shouldn't, unless you have good reason, you shouldn't combine randomized and non-randomized studies in a meta-analysis. Discussion about or guidance on whether or not that would be the same for doing something like effect direction, there's not really been anything written about that, and maybe that's something for us to consider as methodologists in the future. I think there's a bigger, probably an easier response to whether or not you can combine qualitative and quantitative data. And I think a qualitative study answers a different question to a quantitative study. So I think then it makes sense to treat them separately when you do the initial synthesis. There are methods, one in particular called qualitative component analysis, which I think was developed by James Thomas at the Epicenter, and that does allow you to bring together quantitative and qualitative data. But I think it requires a high level of expertise, and I think you have to be very careful that you are using it appropriately and you have enough data to support that, because it requires quite strong data in both the quantitative and the qualitative studies. So why is narrative synthesis falling out of favour? I think because nobody really knows what it means. Narrative is used in all types of research, not just reviews. A review with meta-analysis includes quite a lot of narrative, and we have spent quite a lot of time trying to decide what a good definition of narrative synthesis is, and we haven't managed to come up with it. So I think whether or not the term will remain used, we would rather use something a bit more specific and which we can define, I think, clearer to readers.
Thank you, Hilary. Are there any more questions? You can unmute yourself to ask a question. Okay, thank you, Hilary, for your presentation. Just to remind everyone, the presentation will be made available online with the recording at the Cochrane SA website. Thank you, Hilary, for joining us today.
You're very welcome. It's been a pleasure. I hope it made sense. Yeah.
Okay, communication about the next webinar will be sent via email. Thank you. Bye.
Thank you. Bye-bye.
Bye-bye. Thank